Hello, everyone. Welcome. Take just a minute to read through this slide and we'll get started in a second. All right, we'll go ahead and get started. Welcome, everyone. Welcome to session 10 of Auction Therapy and Critical Care, the case-based series. My name is Sarah. I'll be here with Assist International, helping support the session. So if you have any questions throughout the session or any technical challenges, please feel free to send me a message through the chat and I'd be happy to assist you. So today we're going to be talking about essential emergency and critical care. As always, we have Dr. Eugene leading us today, and I will hand it over to him to introduce his panelists and get us started.
Thank you very much, Sarah. Can you hear me?
Yes, we can hear you.
Yes, we do.
Yeah, very good. So thank you very much, Sarah, for helping us for this term session. So today I will be with Dr. Jean-Paul Vauquier, who will lead most of the session, and I will be available to give comment, to give my perspective, but also I will contribute as much as possible. So we welcome everyone to join us. So we may start with Jean-Paul, and we'll start with the objectives for today, and then we'll start from there. Thank you.
Thank you, Eugene. Actually, we can start without delaying. Welcome all participants, and we hope that this session will be enjoyable. We can start with a 61-year-old patient who presents to a local emergency room with a shortness of breath, dizziness, diarrhea of 7 days of duration. So here we have some objectives that we have to cover. Practice change objective. We explore acute care, critical care, and intensive care. So we list the domain across which acute care occur. We recognize the critical care continuum. We define essential emergency and the critical care. So we recognize two keys, domain of EECG, EECC, identification of critical care illness and the care of critically illness. So we determine critical illness by using warning sign and scoring system. So we improve care for critically ill patients through education and training, guideline, protocol, and the use of cognitive aids. We identify clinical process need for WC. We recognize component of process needed for EEWC. We analyze the gap in institutional resources available for critical care. We also see and we implement EEWC with available resources. Then lastly, advocacy and additional WC resources. So welcome everyone. So without delaying, can go for the next slide. Here we start with some epidemiological data, where we have daily medical.
Jean-Paul, we can't hear you.
Limited, as you can see, this number.
Jean-Paul, if you can repeat what you said, because we lost you a lot.
So we are in cubic meters. Say that again.
Yeah, we didn't get to understand what you said because of low connection.
Oh, sorry. Firstly, I was reading the practice change objective, which was on the first slide. And
Yeah,
now
we
we
are
are on
the objectives. This slide, that's where we lost you.
okay. For this slide, here we are having daily medical oxygen need. This is like an epidemiological data regarding to the need of oxygen, which was due to the COVID-19 pandemic. These are the data which have been produced in June 21 this year, where they are showing how much of oxygen is needed in low and limited income countries. And here also they are showing the cost of that oxygen, where they are saying these are the data from World Bank. Yeah. Can we move on the second slide, the third slide? Okay. So now we are having a case. Remember, to the participant, we are dealing with some emergency cases. So here we have a case I'm setting. Imagine that you are working in a rural district hospital. The nearest hospital is an ICU is 40 miles away. The physician working in the emergency room calls you to come to see a patient that you want to admit to the hospital. Here we have the history of presenting illness. We have a 66 years old man, has 7 days of dyspnea, dizziness, and diarrhea. He reports feeling weak. His dyspnea is worse with extension and better with rest. He received the Johnson vaccine 4 weeks ago. Here we have vital signs. Have respiratory rate, which is 27, heart rate 97 beat per minute, blood pressure 107/59, temperature of 37.5, SpO2 91 on room air, and then he's based on oxygen liters per minute by nasoprons. Then the oxygen saturation improves to 95%. Here we have the practice change objective. So we have to explore acute care, critical care, and intensive care. And then we have to list domain across which acute care or care. And then we recognize the critical care continuum. According to WHO, what defines acute care? To our participants, so you can use chat box and tell us, according to WHO, what is the definition of acute care? How do you? Can you use the chat box? What is acute care? What do you understand by acute care? By using the WHO definition. I don't see people are responding. Maybe I can pick some of the participants. Just feel free to respond. What do you understand by acute care? Eugene, tell me how do you think that what is acute care by WHO? Mm-hmm. I can see some answers from Emmanuel Mutagoma. Acute care is short-term treatment. Can see Eugene, short-term treatment. Can see another one who said is a sudden change of condition of life. Okay. Others, what are you thinking? What is your thought? Mm-hmm. Can see another answer. Active care but short-term treatment for severe illness. Mm-hmm. Can see Daniel to respond to a life-threatening condition as quick as possible. Yes. Okay. Keep giving your thoughts about that. Okay. So let us move. Let us go for the next slide.
Jean-Paul, I have a quick comment before you move.
Mm-hmm.
So,
yes, please.
Sarah, if you can go back and click on that the question above. Yeah, very good. So go down and show a figure which shows a component of acute care. Go down. Thank you, that figure. So I think this is a good summary of how it is difficult to define acute care. So acute care, when we think about a patient who has a life-threatening condition, for example, a patient who have trauma, a polytrauma patient. So when you think about acute care, starting where before even in the hospital, once, for example, the paramedic, but in our system is SAMI, reach the patient. So that's a pre-hospital care. And that's a continuum. From that, we need short-term stabilization, which can be done in our system to a district hospital, for example. And then urgent care, where after stabilization, they think about the next step, where they may need further optimization, and then emergency care, where they need to be prepared for definitive treatment, which may include trauma care, like operation, and then after that, they may need ICU, which is the critical care, and then they will need also like rehabilitation after that. I think we missed rehabilitation on this. But as you can see, acute care is a continuum. So it may start with pre-hospital, stabilization, and then definitive treatment, management of complications, and rehabilitation so that the patient go back to their normal activities. So I think, I don't know if people have more question on that, but that's my way of thinking about acute care. So thank you. Jean-Paul can continue. Yeah. Jean-Paul, go ahead.
Oh, sorry. I was saying that thank you, Eugene, for your input. Actually, this slide is showing where what you have been describing, where the acute care, where it starts, where the acute care status, and how do we define this acute care. And I was saying also that if the participants are having question, so they can use the chat box so that we can discuss on the question that they will be having. Can you have the next slide? Okay, thank you. So this slide is showing, actually the question is, how would you define critical care? Where does critical care can occur, differ from intensive care? Don't know if the participants, they can respond to this question from what they are thinking. How do you define critical care? And how does critical care differ from intensive care unit? Does it intensive care unit equal to critical care, or is something different? Let us hear what you are thinking. You can use the chat box. The question is, how do you define critical care? Is it critical care equal to intensive care unit, or is something different? What is your thought about this statement? So you can still use the chat box if we have some ideas. Try to, there is no wrong answer. Just tell us what you are thinking in your mind.
Yeah, just to make it simple, tell us if you think it's the same. Is critical care the same as ICU? Yes or no? And if they are not the same, what is different?
Tell us, there is no problem. Maybe the barrier is that our participants, some of them, they are not used to work in intensive care unit, but tell us what you are thinking. Mm-hmm. So far, I've received 2 answers from 2 people. I can see the answer from Daria, who said critical care is for life-threatening illness. And Rachel also said critical care as difficult condition. Daniel said is the service delivered for the patient promote his condition. Probably Daniel was defining Daria also said it is the same as intensive care unit. Critical care is the same as intensive care with little difference that intensive care, the patient need more acute care. Okay, this is Mutagoma. So without delaying, we can supplement to your answer. Critical care, where does it critical care occur?
So you can
How does
question?
What did you say, Jean?
Yeah, they can also click on can click on the question. There is an answer there, and then you can help us. Like, yes, answer that. Sarah, can you hear me? Yeah, perfect. Jean-Paul, you can go ahead.
Okay, thank you. So if we remember the question that we were answering, we have the old paradigms where it was started at the emergency medical service, where it started from emergencies, and then emergency room or emergency floor, then to ICU. Since the patient is recovering from ICU, then we go on the floor, the ward, then it will be discharged home or rehabilitation unit. So nowadays, the new one is saying it starts from emergencies, emergency room, ICU, where ICU, if the patient is recovering from ICU, it can go on ward, then later on, it can go on home and rehabilitation. So if we can respond to our question, the critical care, it started at emergency, the critical care condition, it starts at emergencies. It starts at the emergency department, and then intensive care unit is where we are caring these critical condition patient, the patient who are in critical condition, where they are being treated. That's the intensive care unit. So I don't know if you understand how the critical condition started, where does the critical condition started. If a patient is is starting having deterioration. That's an emergence. So, but the emergence is the passage, the patient, where the patient receives the first care or the first attention, but the second or the continuation of the care will take place in intensive care. I don't know if you understand that logics of sequence.
Jean-Paul, I have a quick just comment. My way to see this, I think a critical care as a continuum. So you can provide critical care anywhere, from at the emergency, at the ER, EMS, I mean like pre-hospital, then at the emergency, in ICU, in the ward, and then at home in the rehabilitation. So that's the critical illness and the critical care. But for ICU, so it's the part of the critical care where you have like extensive care for that particular period of time in one unit, which is the intensive care unit. As you can see, a unit is a part of the critical care, but it's not all critical care. So you may receive critical care. You should receive critical care from pre-hospital when the emergency happens, and then at the emergency department, and then in ICU where you need further treatment and stabilization, and you need a lot of equipment. You need also a lot of expertise there. And then once the patient is stable, they can go to the floor or the ward, and then they will be sent home for rehabilitation. But it's a continuum. ICU is a small part of the critical care. That's how I would answer the question. Thank you. Jean-Paul can proceed to the next.
Dr. Jean-Paul, if you're speaking, we can't hear you.
Oh no, sorry. So I was saying, for our case, we saw the case, the history of presenting illness, and now there are some other information which I provided. We have past history. The patient state that he's otherwise healthier, and exercise regular. He used to play football or soccer. There is no past surgical history, social histories, single, lives alone, occasionally take some alcohol, but is non-smoker, no medication, no allergy. On reviews of symptoms, he denies emetemesis, melena, hematochezia, denies also chest pain and no fever. But the chest CT scan, which was done under contrast, it showed bilateral interstitial pneumonitis pattern consistent with SARS, COVID, no pulmonary embolism seen. On the assessment and the plan, you and the emergency department physician decide the patient is to be admitted to the hospital ward with oxygen therapy, antibiotics for community-acquired pneumonia, and dexamethasone for possible SARS-CoV-2 infection. Further test and workup are in the process. So, okay. So here we have some definition from Lancet, where we have critical care and global burden of critical illness in adult. This is a paper where they are saying the global burden of critical illness is difficult to define for several reasons. Reason number one, critical illness cannot be diagnosed with a single test or linked to a single procedure. Critical illness related diagnosis are made using clinical exams and investigation. Often their definition and criteria are debated and changed. So this is one challenge where the definition of critical illness is based, that they are saying critical illness is not diagnosed with a single test. If the physician or the caretakers or the health illness occurs outside of the ICU, data is usually collected within the ICU. The data is incomplete in the highest resources setting and may be absent in a variable resource setting. The third challenge is critical illness happens quickly and has a higher mortality. So patients may never present to an ICU. The 441 setting with more resources will cause more critical disease burden.
Yeah, so just to summarize, because your internet was cutting off, so there are multiple reasons it is difficult.
I was reading about the Lancet,
Yeah, Jean-Paul, would you like me to summarize what you say?
Yes, hello. Please. Yes, please.
Yeah.
Yes.
So, as people can see, it is very difficult to have enough data on critical illness. First, there is no single test where you can diagnose everyone with like critical illness. So second, some critical illness may occur out of ICU, and mostly we collect that information in the ICU. And that brings the third problem, because in low-income settings, we don't have enough ICUs. So it will be very difficult to get data, because most of the people with critical illness will die or have complications outside the ICU system. So then we'll have more data in high-income settings because they have more ICUs. And basically, that's the challenge, is to have a good data set of critical illness globally. And that will bring us to the next question, where Jean-Paul can continue with a question.
Okay. Thank you, Eugene. The next one. We have some question. Which of the following are considered as critical care patients? So we have 5. Early recognition, assessment, decision making, deterioration.
Your internet is cutting.
Deteriorating patient.
Yeah, so I think most of the people got the right answer. So all those items are part of critical patient care. So I would like to highlight the number 4, providing expert assistance in response to concern for patient status. So I think most of our participants, they are called for airway management, so which is a small part of critical care management. And sometimes they are called to transfer patients from one hospital to another one. So, and also you may be involved in a quality improvement to design systems for eye warning signs, for example. So think about that. But the right answer is number 5. So all the above are considered critical care, critical patient care. So let's go to the next, let's see the next slide. I don't know if Jean-Paul is there, the internet is good or not. So if Jean-Paul comes, we will continue. But let's think about the next objectives. So we need to be able to define essential, emergency, and the critical care. What is essential, emergency, and the critical care? So we need to recognize 2 key domains, including identification of critical illness and the care of the critical illness. So we need to be able to identify, but that's not enough. We need to be able to manage. So we need to be able to determine critical illness using warning signs and scoring systems. So I don't know how many systems you use, but we'll have few examples. And lastly, we need to be able to improve care for the critically ill patient through education and training, guidelines and protocols, and the use of cognitive aids. So I think that's what we are doing here. We're doing education and training, and we have been sharing throughout the year guidelines and protocols. So let's start with a question. So tell me if it is true or false. Its critical care and emergency care require expensive technology and high-skilled health providers. Is it true or false? You have like 30 seconds. Very good. It seems like most people think it is false. So you can put in the chat why you think it is false. Give 2 reasons. And then why other people think it is true. Give 2 reasons. You can start by saying it is true because, give 2 reasons, false because, give 2 reasons, so that we can have a good discussion before we proceed. Mukamugwiza Rachel, why do you think it is false? Okay, this is interesting from Emmanuel Mutagoma, saying it is true because you need equipment and skilled personnel. You need, because you need to identify abnormalities and intervene. That's interesting. So let's keep in mind what critical care is. It may start out of the hospital, pre-hospital, where you have just a paramedic with few years of training in comparison to having a critical care specialist who may have like 10 years or 15 years of medical training. Those professionals may have just 2 years of medical training. So just, I don't think it is true. I think, yes, we need equipment and technology and the high skilled health providers, but with raw technology and less skilled healthcare providers, we can still provide high quality critical care throughout the continuum. So think about all the teams we need for critical care at the emergency. They have to be highly trained with many years of medical training? No. Do we need advanced and expensive equipment? No, we may be able to detect all those patients by using a good physical exam and a systematic approach, which can be taught by courses like PLS, CPR, ACLS, and so on. So just keep that in mind, that we don't need things to be expensive only, and we don't need a lot of years of experience and training only. So let's go to the next question. So that brings us to the next question. What is essential emergency and critical care? What is that? What do you think? Just put the answer in the chat. You can put your answer in. You have like 30 seconds. What are the components of essential emergency critical care? Okay, let's go down. I see that people are very quiet. Um, I like the one who said is care given to critical ill patient or intervention done. That's part of the answer, actually. So, in order to be able to provide care, you need to be able to identify those patients. So, but in summary, there's an ambitious answer or definition of what is essential. So, it's the critical care which is given to very critically ill patient in all hospitals in the world. That will be the basic. And those has to do two parts. They should be low cost and they should be able to do identification of critically ill patient and provide be ready to manage essential critically ill conditions, essential critical conditions. So two things, identification of critically ill patient, but also providing adequate care for common critical conditions. And that should be, affordable at low cost. I think that's the summary of what is essential. But this paper will give you all of the details, which we can't cover with the limited time we have. But as you can imagine, we need to have systems to be able to identify um, those patients and the systems to manage common complications. Yeah, keep going down. Yeah, the common conditions we see, as you know, infectious diseases. In our conditions, in our context, we have sepsis, we have meningitis, for example, we have malaria, and then maternal conditions. And you see people with postpartum hemorrhage, for example, eclampsia, um, abortions, and then surgical conditions, which may include trauma, which is very common. And then non-communicable diseases, including hypertension, diabetes, and their complications, which can include myocardial infarction and stroke, for example. So those are the common conditions that each hospital should be able to manage. Let's go down. And we should be able to have emergency department, ICU, and then disposition after the management. I can go down. Yeah, that's a good way of saying it. So you need to be able to identify the critically ill patient here in the left, and then provide essential care. And then that will help us to have effective coverage for emergency, for critical care, for essential emergency and the critical care. So I think that's a good summary. We can go down to our case. So keep in mind our case, and then you remember our patient is sent now to the hospital ward. Despite being on 3 liters of oxygen by nasal cannula, 2 hours later, the SpO2 or the saturation is still low, 26%. So this is an example of identification of critical illness. What is the problem I identified? You can put that in the chat. And think about who is responsible. Who should identify this problem? What do you need to do that? And then what should do next? Or what the management should you provide? So I think that's a simple question, but you can put that in the chat. For example, you may say this is hypertension. The nurse should be responsible, and we should provide fluid, for example. But be precise on this particular example. Yeah, Daniel said the first to attend the case is responsible. That's not specific. Who should be the first to attend the case? If you had that patient in your hospital, who would be responsible and what should be done? Okay, while you are answering, I'll share my experience. So in the hospital where you work, so the nurse will be able to identify the condition, and then we start initial management, and then they will call the rapid response team, which will come to do simultaneously diagnosis and management. Probably the patient will be taken to ICU. Okay, nurse ward. Okay, that's good. So, and then this is just to save time. This patient has hypoxemia, and the nurse will be able to identify that, call for help, and then increase the amount of oxygen, and then initiate um, the the diagnosis and the treatment as the next step. So yeah, let's continue. So yeah, the word nurse calls you. When you arrive, the patient is alert but appear to be working harder to breathe. He can only speak 2 or 3 words at a time. So the respiratory rate is very high, 27, temperature 37.5, the heart rate is 93, the blood pressure is 112/79, and PO2 is 86%, which is 0. So let's go down. So what is an example of a hospital system that serves to identify the deteriorating patient before they become critically ill? So I don't know if you have that type of system, but you can put that in the chat to share experience. What is an example of a hospital system that serves to identify the deteriorating patient before they become critically ill? Yeah, thank you, Leonard. So Leonard shared the experience saying they have a triage system. So emergency room. So in my experience in Rwanda, the issue is that the triage team is most of the time is at the emergency department only. But for other hospital systems where I work, for example, in Canada, the rapid response teams, they are available on call all the time. And they are called before the patient develop complications, before cardiac arrest. So then they will be able to optimize patient and contribute to better quality of care and better outcomes. So I think it's something to think about. How can we have a rapid response team where the nurse who sees the patient in the ward will be able to call the doctor, the other nurses with critical care expertise, to be able to manage the patient before they have complications. Yeah, here are some duties of what they do. As you can see, the medical emergency team of physician will respond to emergencies, follow up on a patient discharged from ICU, and there is critical care outreach as well, including the physician and the nurses, who will be able to evaluate high risk ward patient. I think that's a good way of thinking about our system. Can we rank, for example, our patient in the world from like high risk moderate risk, and low risk, so that we can use all the resources we have to be able to monitor and spend more time on high risk patients. And we'll see in the next slide some of warning signs and other scoring systems you can use. Yeah, here is a good question. So list at least 3 warning signs that patient may exhibit prior to deterioration. So in other words, before the patient have a critical or situation or cardiac arrest, what are the common signs you may see before? So, yeah, I think this is simple but important. Please, everyone, put the answer in the chat. You have 30 seconds. Yeah, thank you, Mutagoma. So they may have low saturation. Yeah, that's very good. They may have gasping. It may be too late for that. They may have low consciousness, dyspnea. Yeah, but we need to be precise. Respiratory. Okay, I'm sorry for the internet. Yeah, so I saw some of your answers, which include like changing and patient condition, but we need to be precise. And the best way to do it is to use a good system, either A, B, C, D, E, or like system by system. So some of the examples is low saturation above 90, high heart rate above 120, low heart rate below 40, respiratory rate above 28, and respiratory rate below 8. So, and other symptoms like chest pain or seizures and a lot of pain. Those are some of the examples you may think about. Let's go down to the next slide. So I don't know if people are familiar with warning signs and systems. So the one which is given as an example is news 2, which is a new early warning sign. Me, I have been using one in obstetrics, which is called modified early obstetric warning sign. But mostly those are based on like vital signs abnormalities. This is one example. And I don't think we need to go in details, but we can go down very fast. So you can see the respiratory rate, and you may think about, is the patient having hypercapnic respiratory failure, SpO2, room air or oxygen, temperature, systolic blood pressure, pulse, consciousness. And also they had COVID. So, but as you can see, those are simple questions to answer as long as you have standard monitors on the patient. I think the most important part is to think about the system and then have it used at a regular basis for every patient. That's my takeaway. We don't need to memorize that. We can always have access via our phone, or we can have that in the chat. So there are other systems as well. There is another one you are familiar with, which is called Quick SOFA. And as you know, we look also for the blood pressure. Systolic blood pressure should be above 100. And we look for respiratory rate, which should be above 22 for Quick SOFA, and consciousness, where the patient should be fully awake. If you have two abnormal signs, then that's positive. So let's go down. Yeah, let's see the update of our patient. So you decided to increase the patient oxygen therapy by switching to a mask with reservoir and increase the flow to 15 liters. So this is an example of care of critical illness. How do providers know how to give the appropriate care? So in other words, how do you know if you are providing appropriate care? I don't think we can just discuss how we can achieve that. So let's go down. Yeah, probably you can click on that and see if we can find an answer there. But mostly, okay, yeah, I don't think there's information there. But we need to think about, do we have guidelines? Do we have protocols? Do we have appropriate training? And then do we have the resources to implement that care? So in my way of approaching this, think about your training. Do you have enough training? Then do you have enough resources? And then do you have guidelines and protocols in place? That's the way I would think about it. So let's go down. Yeah, so education and training, we give some examples of courses people can take to have more training. So there's the basic emergency care course from the WHO, which should be free. That's the link there. Yeah, so we don't need to go into details on that, but this is available to you guys and you can use it as needed. Yeah, protocols. So there are some protocols which you may use. There is most of these protocols are from US, but feel free to use one of them as you can see fit. But remember to adapt them to the context of Rwanda. Let's continue. That brings us to a quick question. So true or false? During the stress of a critical event, physicians are more likely to implement or knows best practices. True or false? You have 30 seconds. Okay, interestingly, 50% think this is true. So why do you think this? Okay, so just to help you answer this question, there is an evidence showing that during stress, people have access to less than 5% of their cognitive capacity. So there is more risk to make errors when you are stressed. So the best way to approach this is to use cognitive aid. Yeah, so we have a good example of a cognitive aid here, which is the Stanford guideline. Actually, there is a new one, but you can use this one for now. But there is a recent version for 2021, which has more information. But that's a good guide you can use, especially when you provide anesthesia and there is problems. And you have shared this before. There's a link here. It's free for download as long as you give your email. Okay, let's go back. There is another one from the same group but focusing on obstetric complications, which is very good. And I will recommend everyone to download that. Very good. Okay, so let's think about the last objectives. So we need to be able to list the clinical processes needed to identify uh, critical care illness. We need to be able to recognize components of hospital readiness needed for essential emergency and critical care. So I think we can go down and we see the summary of essential and emergency critical care, which you have seen before. So the most important part is to have the capacity for identification, which will include at the hospital level, we need hospital readiness, and the clinical practice level, we need like physicians and all the health personnel. Um, and also remember to have essential protocols and the guidelines in place. So both for identification, but also both for essential care. And after you do that, you need to be able to provide stabilization, and then you need to measure the survival for critical ill patient. And I think that's where we need more work in our context. I don't think we have a good data set for outcomes of our patients. So we have managed to do a few retrospective studies, but we need to do more. Let's go down on this table and see some examples of essential emergency and critical care in hospitals. So we will not go in all the details, but as you can see, we need a structure at the hospital level to be able to identify a critically ill patient. And as you said before, we need a triage system. Word-based triage. This second one is important because most our hospitals have triage at the emergency, but we need those systems that are at the ward as well. And we need to train people at the emergency department, but also in the ward in emergency care. And that's part of what we are doing. You may be like comfortable with everything we are saying here, but it's your job and the responsibility to share the knowledge with the nurses and other staff in the hospital. And we need to have a price estimator, for example. So we need also clinical processes, including triage tools. And that may include, for example, early warning sign. So in my experience, some of the initiatives which I started, it's difficult to maintain them. So we started early warning sign for hospitals, but I'm not sure they are still being used. So we need also to find, to be able to find structures at the hospital level. So for example, availability of emergency department resuscitation room, drugs and equipment, you can go down. So oxygen, and trained staff and guidelines. So this is, they will have a good list of things we need to be able to have in place. And training on use of appropriate airway equipment, oxygen, IV fluid. So as you can see, training is part of it as well. And then after that, we need to be able to measure progress. So how are we doing against the protocols? And I will encourage you to find teams for quality improvement, because it's a lot of work, and you need the advocacy to have time to do that. So an example of what to measure is how many critically ill patients are identified on time, and among those, who are they receiving appropriate care? Okay. So, and then, yeah, that's just a summary. I don't need you to memorize that. You have access to this content. Let's continue on the specific content of essential emergency and critical care. Hold on. Yeah, so this is just an article which has all of that. So there is a link where you can download the whole article. Yeah, we don't need to answer that because we have already discussed about this. So triage, I think that's a good summary. So you need to be able to do the vital signs, for example, and level of consciousness. And this can be done easily with a good physical exam and essential vital signs. Continue. For identification, the service should be available 24 hours a day, which is expected. And also, we should be able to provide that service during and after the operation or anesthesia, and during and after transport. I think that's important. So for the transport, let's think of ambulance as the hospital in movement. So I think we need to be able to provide the highest care during transportation, and that's our role by having good equipment in the ambulance, but also trained personnel. And lastly, timely transfer. Yeah, let's continue down. Yeah, so among of the examples of care which is provided, and I don't expect us to go into the details, but one of the systems is to use ABCD system. So including airway, breathing, circulation, disability, and exposure. So I don't think we need to go in details. This is the slides are available, and most of you guys, you have been trained in the BLS and the ACLS, and you are familiar with ABCs. That's just a reminder, and you can use this to train other healthcare providers. Okay, so and this brings us to the hospital readiness. So we are coming from individual level and teams, and we are looking at the hospital. So let's go down and see some of the key elements the hospital has to meet. As you can see, you need to have good enough equipment, consumables. Those are the examples: drugs, human resources, training, and guidelines. So the Ministry of Health of Rwanda, the WHO, also have published guidelines on the essential equipment supplies needed in emergency departments, and you can refer to those for our context. And one of our residents at the University of Rwanda has conducted one study at CHK looking at that. I will share the result once it gets published. So let's go down. Yeah, so this is just a good guide, and it's in the same line. So we need, those are the what we need in the ICU. As you can see, you need more equipment. You need suction machine, for example. You may need ventilators. You need more oxygen, and so on. That's just a guide you can use to evaluate your compliance or your readiness to take care of critical care patient, critical ill patient. Drugs, those are some of the examples. But that's just the basic. That's why we say the essentials. Each hospital should have that. But if you have the capacity, you should aim for more. Yeah. Processes. So we need readiness at the individual level, at the hospital level, but we need the processes in place as well. So you may think about having more senior staff, for example. You may think, how will you treat people who can't afford, for example? So how will you be able to provide isolation, for example, infection control, communication among teams? Let's go down. So there are multiple things to consider. Those are a few examples of danger signs to think about. So I don't think we need to go into details because you are like health professionals taking care of those patients already. That's a guide. Okay, so I think this is important. You need to have policies of what should be done. So in the example is like oxygen saturation using a pulse oximetry at least every 6 hours for every patient. I think that will be a good goal if we can do that. So if, for example, use of anticoagulants, use of corticosteroids, so antibiotics, we should have policies like guiding our practice so that we have a standard of practice rather than an individual-based decision. So let's go down. Yeah, during COVID, we should think about how we approach patients with COVID-19 and other infection control. And also the training. So if there's a new disease, like now during COVID, how are we making sure everyone is aware or comfortable in doing their job, both by protection, but also by training? Very good. So yeah, that's the summary, an overview of readiness of hospitals in essential emergency and critical care. So let's think about other objectives, which include how can we analyze the gap in our institutions? How can we implement essential emergency and critical care with the resources we have? And how can we do more advocacy for oxygen and the other resources? So let's go down. This is an example on how we can conduct quality improvement. And this is the basic. I don't expect you to be to become the expert in that, but that's how we can think about these problems. So the reality is what we are doing now. And the best practices is what has been published or recommended. And we need to identify the difference of what we are doing and what is expected as gaps. And then we set goals. So it's important to set goals you can achieve with the resources you have, rather than thinking of things you can't change. So, for example, you may train more people on how to use early warning signs systems, for example. It may be difficult for you to buy pulse oximeters or buy oxygen or set up an oxygen plant. So if you think about setting up an oxygen plant, that's an unrealistic goal. But training people in the use of pulse oximeter, it's a realistic and feasible goal. So that's how we think about quality improvement. Is the thing among the things we need to improve on? What are the things can we do with the resources we have? And for the things we can't change now, how can we do advocacy? Who can make those changes? Probably it's the Minister of Health or international donors. And what are the best way to approach them? Probably you need to write commentary, you need to write policy reports, you need to do research. So, but there are things you can change, which are with the resources you have. That's how we can think about gap analysis. So let's go down. Yeah, so we may think about, what can we change, or what are our current practice if we identifying critically ill patients? Are we ready with enough staff? Do we have enough equipment and supplies? Do we have enough space? Do we have enough systems? And the systems including guidelines and protocols. So let's go down. So once you see the gaps, you need to provide action plans. So, and you can use SWOT analysis or SBAR, SWOT analysis including our strength, weakness, opportunities, and the threat we may have. So we'll see that down. Let's take one example. So you find that you have issues with respiratory distress patient, and there is no policy of using SpO2. So your best practice is to provide SpO2 should be included with all vital signs. So identify the gap, there's no vital signs policy. So action items, you specify that SpO2 should be part of the vital signs. So, and you will monitor if that is being done by looking on the chart review. That's just a good example of action plan. So think about that. Yeah, let's go down. Yeah, we can continue. Yeah, this is S-bar. You need to think about our situation now and what was leading to the situation, which is the background behind. So assess the situation and provide the recommendation. So that's just a summary. I don't need to go in details because I don't expect everyone to be an expert in this. But as long as you have a team, you may find someone in the hospital who has expertise in quality improvement, and then you implement the project together. By the time we finish the project, you will have enough expertise. That's my recommendation. And also we think about collaboration with people at the university or international collaborators. Yeah, so strength, weakness, I don't need to go in details about this as well. So, and that brings us to the end of our discussion. So, and here are our objectives. Let's see if we have met those objectives. So, first, our goal was that at the end of this discussion, We should be able to define what is acute care, what is critical care, and what is intensive care. We should be able to list the domains across which acute care happens. So we need to be able to do exploration of the critical care continuum to define essential, emergency, and critical care, which we did. We should be able to list the two key domains of essential, emergency, critical care, which include identification and readiness to manage essential or common critical care problems. So that the other objective was to identify critical illness using warning signs and scoring systems. So we gave example of news too, and also a quick software. And then the other objective was to improve care for critically ill patients through education and the training and the guidelines and the protocols and the use of cognitive aids. So we gave examples of the Stanford guidelines for common complication in the operating room, but also for maternal care. So the other objective was to list the clinical processes needed for emergency, essential emergency and critical care. So we gave just an
Dr. Eugene, we're losing you. We cannot hear you. We still can't hear you, Dr. Eugene.
Yeah, if there are questions, please put the questions in the chat. Otherwise, we're planning to have the next session in November. And the last session will be in December, on 18th of December. So, yeah.
Yes, excellent.
Sarah, back to you.
Great. Thank you, Dr. Eugene, and thank you, Dr. Jean-Paul, for this excellent session today. It was very informative. So as Dr. Eugene said, please feel free to ask any questions. You can join our WhatsApp group here at this QR code and ask questions there and engage with the community. And then everything that you saw today, all the presentations and the resources and the recording is all available on the Learning Resource Center, which you can get for free. It's a free open access source. So please go check that out and see all of these resources. And the recording of this presentation will be sent to you later via email. And then as Dr. Eugene said, please join our next session, session 11, on November 27th. We'll be talking about referring patients to a higher level of care. And as always, if you have any questions, please email us at echo@assistinternational.org. So thank you again to our panelists and to Echo India and Stanford for making this possible. And if there are no other questions, then we will end for today and see you in November. Thank you, everyone.
Thank you, Sarah, for your support today. And thank you, everyone, for joining us. So have a nice weekend. Bye.